Some wrapping, compression stockings, a pneumatic compression pump. Get the patient on a walking program to use the calf as the muscle pump to help bring blood back up to the heart. Okay, we're going to educate the patient to elevate their limbs, especially at the end of the day. What do we need to think about in terms of wound care? What's our main concern about this type of wound? Well, the edema is our main PT treatment that we're doing to help with the pathology. But what about it has nothing to do with the wound. We do want to prevent infection, and how do we do that? With this type of wound. Get rid of the exudate. It's a lot of exudate, so we need a dressive that's absorptive to take out the exudate. Because why is increased amount of exudate increase your risk for infection?
Bacteria likes moisture.
Bacteria likes moisture. Okay, we'll go over what's in Una's boot later. Okay, so occlusive dressing means that you're protecting it from outside pathogens, but you're still allowing it to breathe. Occlusive actually doesn't mean completely occlusive. It does allow for air to gas exchange to happen. But it protects the wound from external debris or bacteria. And again, we're going to want to do something that absorbs the exudate. Growth factors are just like proteins and things like that that help promote wound healing. Okay, what's the pathophysiology of arterial wounds? One besides the usual. The pathology, say that? Say it again. Arterial insufficiency. So what does that mean blood flow wise?
Not getting enough oxygen.
So just give it to George. You're giving the right answer. So what's happening to the blood? Can't get down to the extremities. So then what's going to happen to the tissue in that area? It will die eventually if it doesn't have enough oxygen. Okay, so lack of blood flow, dangerous, because if it goes on long enough or gets severe enough, the tissue will start to die. The most common place to get a wound is in the lower 1/3 of the leg, but especially the distal toes and dorsum of the foot. Those are most common. Now these wounds look different than venous wounds. They have well-defined edges. It's going to be very, very clear where the wound ends and the periskin starts. These wounds are also very deep. And most often we can't tell how deep they are because necrotic tissue is covering it. And we don't want to remove that necrotic tissue. Why? They won't have any protection. Why?
Because beneath that eschar
It's
is just tissue.
just tissue, and why do we remove eschar in other pieces and not with arterial wounds?
Nutrition artery.
You can't, new tissue can't grow back. Okay? So in general, you debride necrotic tissue because that necrotic tissue will prevent the wound from healing. But in an arterial wound, there's no blood supply. So new tissue is never going to be formed. So if you remove the dead tissue, you're potentially just exposing the healthy tissue underneath, and no new tissue is ever going to grow. Okay, these wounds also tend to be very dry. And we often see yellowed nails. And we have dependent rubor, which means you elevate the legs 30 to 45 seconds, put them back down in a dependent position, and what will you see happen?
Color.
Flushing.
It'll be a major flush of redness. Okay, so the only treatment that can be done is medical. They need to do something to reopen that blood flow, reopen that blood supply. So in the meantime, if we're seeing someone, we're going to keep the wound dry and protected. What if one of the symptoms our patient has is intermittent claudication? Because we don't want them just sitting on their butts waiting to get better. You might still want to exercise them. So, how do we manage the symptom of intermittent claudication? Stop exercising at the intensity it occurs. So only exercise at the intensity just below where their symptoms of intermittent claudication come on. That way they can still exercise. So just like with the heart, you exercise them just below when the angina comes on. These wounds can tend to be very painful as well, more painful than venous wounds. And elevation will cause more pain.
What's the reason behind that? The difference in pain between arterial and venous?
Because this one's more of a secondary to pressure. And this one is because things are dying. So death hurts more than bloat.
Yeah.
McGuire isn't.
What was I gonna add in here? Oh, yeah. So elevation is contraindicated with arterial wounds. Okay, what is the pathophysiology behind lymphatic wounds? Lymphedema. Who wants to explain what lymphedema is?
Backing up of the limbs.
What of the limbs?
Backing up. Yeah.
Increased interstitial fluid. Why does it happen?
Obstruction of the lymphatic system.
Hmm?
There's an obstruction of the lymphatic
So
system.
there could be an obstruction in the lymphatic system. What else?
Lymph nodes are removed.
Removal of lymph nodes, which is most commonly done when?
Breast
Cancer.
Any cancer. Any cancer. And they can be killed by radiation or they can actually be removed. Because besides our axillary area, anyone know where we have other clumps of lymph nodes?
Neck.
Neck. So what if they have throat cancer? Or even lung cancer, the axillary ones will get affected. What about in the lower extremities?
Inguinal area.
Inguinal ligaments. Okay, so prostate cancer, it happens a lot. Or cervical cancer. Okay, so lymphatic ulcers are going to be most common in the arms and legs. The more distal you get, the more common it is. Legs have a lot more fluid, so it's more common at the legs. So there's going to be a ton of edema. This is lymphedema. The wound itself is going to be very shallow and kind of scattered. Think of it as a whole bunch of tiny wounds scattered over one area. And they are going to be oozing, very, very wet. The skin around those wounded areas is very firm and fibrotic because it's so edematous. Okay, now why do patients who have lymphatic ulcers, why are they at increased risk for developing cellulitis? You will be able to answer that by the end of the day today. I'll tell you what cellulitis is.
Inflammation.
Okay, so we need to protect the wound to decrease that risk of infection. And again, just like with venous ulcers, our number one treatment is going to be addressing the edema. We need to get the edema down through elevation, manual lymph drainage, compression therapy. In terms of the wound, because there's so much exudate, we need an appropriate wound to be able to absorb all that exudate, while still protecting the surrounding skin. Okay, so I recommend that you be able to draw this chart from memory for your wound care exam, which is in exactly 1 week, and I will send you the study guide later today. Yes.
I just didn't see anywhere in treatment goals and procedures for wound care, any of the monobasic electrical modalities for wound care.
Because we haven't done
Okay, but it would or would not be appropriate for cervical disease or rheumatology, all of them appropriate?
Okay, questions on this chart? Did everyone get it down, or you need another minute? Did everyone copy it down? Or you can draw it from memory.
Take a picture of that.
Okay. Not yet. I know, we're about to look at some pretty nasty pictures.
Yes.
You're all on a diet. Watch movie pictures before dinner.
Doesn't count.
Which part of it?
Okay, the last type of ulcer we're going to talk about is a neuropathic ulcer. Sometimes referred to as a diabetic ulcer. So neuropathic ulcers occur secondary to diabetes. Uncontrolled blood sugar eventually leads to degeneration of the capillaries and these small nerves, which is called neuropathy, diabetic neuropathy. These wounds are going to be located on weight-bearing surfaces of the foot. So all the pressure points of the foot. So they're kind of like pressure ulcers of the foot, but because of diabetes.
And you don't have diabetes.
The most commonplace is the first met head of the foot, the plantar surface of the first met head. Like I said, they could have sensory loss, they could have motor loss, and or changes in the autonomic system because of this neuropathy. The wound is going to be surrounded by thick, scaly calluses. So the surrounding peri-wound is normally very, very dry. Okay, Okay, induration and skin fissures are common. Okay, so this is where the skin like kind of breaks open in a slit. It literally is a fissure that's split open.
It's called induration?
No, that's the skin fissure.
Oh. What is induration?
Induration is the wound bed is significantly lower than the peri-wound. Pedal pulses are going to be diminished. There is a change in circulation secondary to the diabetes. The wound bed itself is usually very granulated. Okay, so you're going to see this red, beefy wound bed, and then coming up out around it are dry, scaly calluses. And the wounds themselves have almost no drainage. Okay, so diabetics, because of all the pathology of what's happening with blood sugar, it's affecting a lot of different systems. Then on top of it, if it's affected the sensory system, they can't feel when there's abnormal pressures on their foot or abnormal friction or shearing. So they are very high risk of developing an ulcer. Once they have that ulcer, it's very, very hard for that ulcer to heal because there's been changes in the blood supply. We don't have enough blood getting to that wound area, so it's going to take a really long time for that wound to heal. So number one is prevention, just like pressure ulcers. The number one treatment is prevention. They need to keep their blood sugars under control. They also need to take care of their feet. They need to be doing daily foot checks. It is very important that they moisturize. They are prone to getting this dry, scaly skin. So it's not for cosmetic purposes, it's actually for the health of your skin, that they need to moisturize their feet. They should never walk barefoot. They'll always be in supportive footwear. And you have to be very careful when cutting toenails. It's often more recommended to see a podiatrist to do it for them. Because again, you nick the skin, it's going to turn into a wound, it's never going to heal. He's considering becoming a podiatrist. He was really excited about that. Yeah, that's don't be a podiatrist. Okay, choosing the correct sock and footwear is important. You need to wear natural fiber socks. Why? What would the purpose of that be?
Moisture wicking.
Yeah, so
Less
it pulls
bacteria.
moisture away from the feet. It doesn't trap it in there.
Less bacteria.
Less bacteria.
Dyes.
So there's things called diabetic socks. Okay, shoes. They need to be able to wear shoes that fit very well. They should always inspect them prior to putting them on. Because again, if there's something weird or rubbing, they're not going to be able to feel it. And they have to be careful about breaking in new shoes. So every night when they check their feet, what are they going to be looking for? What, before the skin becomes open, what would you see? Redness, or change in the density of the skin. Is it thicker in one area? Is it a different color than the other areas? So that's a sign that there's been excessive pressure, shearing, or friction on that area. They need to make sure to correct it, or they will end up with a wound. Okay, some assessments. We need to be able to quantify the degree of the sensory loss with these patients. So the most standardized test is the Weinstein monofilament test. Okay, so it's testing basically for the ability to sense pressure. But if the patient cannot feel, write this down, 10 grams of force, they are considered to have lost protective sensation. The patient cannot feel a Weinstein monofilament of 10 grams. They are considered to have lost protective sensation. Protective sensation. So even though it's technically not a sharp dull test, if you can't feel a pressure of that much, means there's no way you can sense noxious stimuli on your feet. Now, what sort of sensory loss, which eventually could lead to motor loss and diabetes, what sort of pattern does the sensory loss show? Distal to proximal, which we call, yeah, stocking and glove distribution. If you picture wearing stockings or wearing gloves, that's where they're going to have the most sensory loss. Okay, so if you see stocking glove distribution, think diabetes. Okay, now we're using a different grading system to grade diabetic wounds. So remember, we already had one for pressure ulcers. This is a different one for diabetic ulcers. It's called the Wagner ulcer grade classification. Okay, the higher the number, the worse off you are. So 0 is pre-ulcerous lesion, aka when you have seen those changes in the color of the skin or the consistency. Could also be a healed ulcer or just a bony deformity. That is a 0. 1 is where you have superficial ulcer without any subcutaneous tissue involvement. So, what levels of the skin may be affected? Epidermis and part of the dermis. But if you get through all of the dermis, you're going to expose subcutaneous tissue. So that would be a 2, a deep ulcer penetrating through the subcutaneous tissue, and that could be any subcutaneous tissue, muscle, tendon, bone, fat. Okay, so it's a Wagner grade of 2 if it's penetrating so that it's exposing any subcutaneous tissue. Okay, 3 is when the bone becomes involved in some way or another. Okay, so if you see ost and itis, means there's some sort of inflammation of the bone, which is not good. Once it spreads to the bone, you're going to have to remove that bone. 4's getting worse here when it becomes gangrene. 5 is gangrene requiring amputation. So I guess 4 is if they still have hope it'll heal. Not likely. Gangrenous penis.
No one's gonna want to touch that.
That's what we're saying. Greatest
Rap song.
right to the penis. Okay, so what are we going to do for treatment? We already mentioned we have to do education, education, education. Protect that area. Tell them that they need to do daily foot checks. Tell them they need to get their